Okay, it looks like the number of participants joining is settled. I'd like to introduce myself first and welcome you to the SAEM Research Learning Series. My name is Joseph Perry. I'm coming to you from Brown University, and I'll be moderating today's event. Today, we're going to be discussing retrospective chart reviews. We have two outstanding experts in the field. First, I would like to introduce Dr. Bryn Mumma. She's Associate Professor in the Department of Emergency Medicine at the University of California, Davis. She is a graduate of the University of Penn and the University of Pittsburgh affiliated residency program. Prior to joining UC Davis faculty, she completed a research fellowship, which included the Mentored Clinical Research Training Program, and earned her Master's of Applied Science degree in Clinical Research. This was followed by completion of the NHLBI K-12 Research Career Development Program in Emergency Medicine. Dr. Mumma's research focuses broadly on outcomes and systems of care in cardiovascular emergencies, with particular interest on high-sensitivity troponin, myocardial injury and infarction, and out-of-hospital cardiac arrest. She's an active member of SAEM. She has chaired the SAEM Bylaws Committee and the SAEM Grants Committee. As chair of the Grants Committee, she has also served on the SAEM Foundation Board of Trustees. She has participated as faculty for SAEM's Grant Writing Workshop, the Research Learning Series, and the ARMED course. She is a recipient of numerous awards, including the Early Investigator Award from both the Society for Academic Emergency Medicine and the American Heart Association Resuscitation Science Symposium Young Investigator Award. Welcome, Dr. Mumma.
Thank you. It's a pleasure to be here.
Next, I would like to introduce Dr. Peter Pruitt. He is Assistant Professor of Emergency Medicine at the Northwestern University Feinberg School of Medicine. He received his medical degree from the University of Maryland, a Master of Science from Northwestern University, and completed residency training at the Brigham and Women's Mass General Hospital Harvard-affiliated emergency residency program. This was followed by an AHRQ-sponsored T32 Fellowship in Health Services and Outcome Research at Northwestern University. Dr. Pruitt's research focuses on improving processes of care for emergency department patients, especially those with neurologic emergencies. He has related area of interest in patient risk stratification, especially the creation and validation of clinical decision tools. In 2018, he received the SAEM Foundation Research Training Grant for his work to create a clinical decision rule for patients with subdural hematoma and preserved consciousness. He currently studies interhospital transfer processes with support from AHRQ. Welcome, Dr. Pruitt.
Thank you.
So today, as I noted, the Research Learning Series will be focusing on retrospective chart reviews, and we're very lucky to have both of these field experts with us. If anyone has any questions, please feel free to put them in the chat as we go along or to hold them till the end. We look forward to having an outstanding discussion today and discussing today's topic. So in order to start off, we'll be switching back and forth between each of the panelists today to answer some questions about the Research Learning Series. So the panelists, I'd like you to first start off by discussing your most successful experience in retrospective chart review and a few things that helped you to become successful and some shortcomings or regrets. And I'll turn it over to Dr. Mumma first, please.
Sure. So mine was probably my most recent study, in no small part because I learned from my ongoing training experience as well as my prior mistakes. So this study was a prospective before and after cohort study of over 1,000 patients who were undergoing troponin testing in the emergency department. But it also involved chart review following the index visit and then again at 30 days and at 1 year. At 30 days and 1 year, the chart review supplemented live direct patient contact via phone, email, or text. So with this study, it was a pretty large study. We were prospectively enrolling patients and we were enrolling them very rapidly over a relatively short time period. So I invested a lot of time sort of upfront, developing the data dictionary, building the REDCap database, and training my data abstractors. I created a guide for the data abstractors, and I was very careful to design the REDCap forms to follow the flow of the electronic medical record, so it was easy for them to get the information from the medical record into the database. I also included reminders for the abstractors about key definitions of variables within the REDCap database, so they had everything in one place as they were doing the chart review. And then what I did is on every every page in my REDCap database, at the very bottom, I just put a free text field where they could ask any questions the abstractors had that they wanted to review at our next team meeting. While it was fresh on their mind, they could put it right there in the database, and then we would filter the database for those questions during our next team meeting. And then finally, I was very careful to code the data in a way that allowed for analysis. So once the data were exported from REDCap, they could be easily analyzed in Excel or Stata or R or any other statistical analysis program. I worked closely, I know this session is about manual chart review, but I worked closely with our IT data analyst to directly export readily available variables, things that are discrete fields in the electronic medical record, such as vital signs and lab results. And then I bulk imported those into REDCap to really improve our efficiency and just prevent simple transcription errors in these fields. Once we were ready to go, after each abstractor independently reviewed 5 charts, I asked them to pause so I could review pretty much every single data element they'd abstracted before proceeding. Then once people were up and running, we scheduled team-wide meetings at a cadence of about every 1 to 2 weeks, and used group emails to discuss questions to really ensure that everybody was on the same page throughout the chart review process.
Thank you. Dr. Pruitt?
So a recent study that I completed was actually generously funded by the SAEM Foundation Research Training Grant. And that was a validation study of a decision rule to identify patients with low-risk subdural hematoma. So kind of patients who presented awake to the hospital, but ended up having findings on their CT scan. And this was a large kind of database retrospective study. Over the past decade or so, Northwestern has built a really large scale enterprise data warehouse. So it comes from the kind of 11 hospitals within the Northwestern medicine system. All of our EHR data gets kind of pooled in there. And then you can essentially abstract data from that via SQL query, which has pluses and minuses. The minuses are they've essentially closed off the kind of front-end Epic instance to data abstraction. So if we want to abstract data, we have to get it from the EDW first, which means that there's a lot more kind of data organization and kind of data collection work that has to happen using essentially SQL and things like that, rather than kind of just saying, all right, we're going to find a bunch of medical record numbers and go from there. And so this really takes a lot of kind of upfront organizational work. I happen to be a database nerd, so it's a thing that I really enjoy doing, and I kind of enjoyed building the databases and figuring out the queries and organizing all this data. And it meant that instead of doing this in kind of kind of Epic with REDCap, we did it kind of all in one really big SQL database and organize the data that way. And it was a really large endeavor. I will totally agree, and I want to double emphasize what Dr. Muma said in terms of that really planning is so important. And so we created kind of a data dictionary first. We created clear abstraction forms. We went through every step of the process. Again, did the exact same thing where we did trainings first, looked through the first 5 or so records that everybody had abstracted, then kind of did every 100 records or so, made sure that inter-rater reliability was roughly the same. Because if you don't do that, you're gonna really introduce a lot of chances of bias.
Thank you for that. And then also thank you for plugging the SAEM grants, which should be coming out shortly. So people should definitely be looking forward to that. The next question I have is, can you describe some of the overall benefits of retrospective chart reviews and some of the limitations? And maybe we'll start again with Dr. Muma.
Sure. So chart review has some very obvious advantages. First, it's relatively inexpensive. I think both of the studies that we just discussed were funded by grants. Mine came from a private foundation, but these are relatively inexpensive, and sometimes they can be done without any external funding at all. You don't have to pay someone to screen patients 24/7 in your emergency department to get those eligible patients. They also take a lot less time to complete than prospective studies, particularly for rare diseases or things where you need a long time frame. If you're looking at a prospective cohort and you need 5 years worth of patients, it's going to take you 5 years to prospectively enroll those patients, whereas you can have 5 years of retrospective data almost immediately, within a few months usually. And this makes chart review feasible on the 1 to 2 year timeframe that most residents and fellows and even junior faculty are looking for, because we want to get these projects completed, get some projects under our belt, develop our expertise in these content areas and these research methods. Chart review is also really good when you're looking at rare diseases or harmful exposures, things where it might be unethical to randomize patients to conditions such as toxic overdoses, envenomations, environmental exposures. All of these things are great case studies for chart review. And then finally, you should not do a chart review because of the expedited IRB process, but it is a nice benefit that most chart review studies can undergo an expedited IRB process. That probably looks slightly different based on your institution, but most places this means it can be approved within days to weeks compared to weeks to months to years for a larger observational study or clinical trial.
Thank you for that. Dr. Pruitt, do you have anything to add?
I will kind of talk about, I guess I'll hit up some limitations here. Retrospective studies, and we'll talk about this in greater detail, I think, over the next probably remainder of the time, but do have the potential to introduce large amounts of bias if you don't thoroughly plan your data abstraction, if you're not really careful. Abstractor bias of key variables. So like if your abstractors know what your hypothesis is and know the outcomes, they may say, oh, that person, maybe doesn't meet that criteria, or maybe does meet that criteria. And they may be able to kind of fudge looking at it to get there. And that may be totally subconscious. That's not necessarily something that's not because of any intention or any intentional malfeasance. The choice of a highly subjective outcome variable can be really problematic. And the choice of an outcome variable. So we really want, and I'm going to come back to this a couple more times, but we really want hard outcomes, okay? So like there's an old kind of thought in this that like mortality is your best outcome in a retrospective study because it's not subjective. Whereas even like, in my subdural hematoma studies, I talk a lot about surgery, but it's unclear, but the difference between somebody whose GCS declined and therefore needs surgery versus someone who got surgery 5 days later on the floor because they had a chronic subdural hematoma and they had a mild headache and they were like, well, I guess we're going to have to operate on this. That's a really big difference, but both are kind of coded as the same outcome. And it's almost impossible in a retrospective study to determine which of those two outcomes happened and to determine kind of whether it was, an emergent surgery or just an elective surgery. So making sure that you have really discrete outcomes is really, and input variables is really critical. And not having those introduces a major limitation.
Thanks for that. And I definitely agree that whenever you have a trainee on a very short time course, this is definitely one of maybe the better study methodologies to go forward with, just to make sure that you can try and get things done on time as opposed to prospectively enrolling. Which leads us to our next question. If someone were to conduct a retrospective chart review, how would you get started? Can you talk about your planning and the overall methodology for this type of research? And I think maybe we'll start with Dr. Pruitt this time.
Sure. So I think most importantly, and again, we've been harping on the same things. This may be into the repetitive, but come up with a robust research plan beforehand. I like to start thinking about determining a research question first. If you're studying an intervention, I like the PICO framework, so patient intervention comparator outcome, as a way to kind of start thinking. We use it to assess literature, but you can also use it to kind of plan what you're going to plan your study. I know that power calculations tend to be something that makes everyone's eyes kind of glaze over and say, I could never do that. I need a statistician to do it. You really don't. It's not terribly difficult to do. So performing a quick power calculation to determine how many patients, and often if you're doing kind of like predictive studies, you want to also know, in addition to how many patients, how many outcomes you're going to need. So how many patients you're going to need to meet an outcome to determine the appropriate power. Once you do that and you have an idea of kind of how many of these types of patients you see a year, predetermine your start and your end times. You don't want to say we're just going to go till we find this. That does have the potential to introduce some bias. Similarly, make sure that you have a robust search strategy and then stick to it. Don't exclude charts arbitrarily. Don't just be like, oh, I don't really like the look of that. You need to include every single chart, and you need to have a pretty clear method to show why you're excluding charts, and your reasons for excluding charts should be determined a priori. determine where all of your key data is coming from, and then create plans for data abstraction. So make sure you have a good data collection form. Make sure you have a plan for the management of conflicting data. So kind of an abstraction hierarchy. So for example, let's say again, I'm going to go back to this subdural hematoma study, but we had to assess GCS. And there's GCS that may be obtained by the emergency physician, and then it may be obtained by the neurosurgery resident, and then it may be obtained by kind of the inpatient neurocritical care team or any. And so you have to decide which is the first one we're going to look at. We decided that the neurosurgery resident was our best option. Some people may quibble with that choice and say we should have gone with the emergency physician, but we had to pick one, and we had to say this is the hierarchy we're gonna go with in order to make sure that we're trying to get the best data, and then talk about and then figure out your plan for the handling of missing data. In retrospective studies, you're almost always going to have some forms of missing data. You have to decide if you're going to do like imputation, if you're going to do a sensitivity analysis that's related to it, kind of what your plan is going to be for that, and that's a whole different kind of lecture. Next, create a standardized data collection form that holds all the key data. Use it a couple times, especially if you're going to be doing like hundreds to thousands of charts. If you can make that data collection form 1 minute faster in the process of doing it, you will save yourself hundreds of minutes down the road. So just making sure that you have that data collection form as efficient as possible is really key. Then determine who's going to abstract your data, train your abstractors, have periodic meetings to monitor their performance. And then make sure to think about, this is kind of one of my like pro tips, is don't do all of this data abstraction, only write one paper. Like if you're going to abstract thousands of charts, figure out how to write 2 or 3 papers out of it. You can almost always do it. And it's, I have one data set that I wrote like 4 papers out of. And it's really important to be able to kind of come up with different ways to look at your data set. And that'll really enhance kind of academic productivity.
Excellent.
Thank you for those tips on working harder and smarter and not harder. Dr. Muma.
Yeah, I agree with everything Dr. Pruitt said. And I would say, going back to the beginning, the first step is really to make sure that you're asking an appropriate question. There are some studies that some questions that just can't be answered with chart review. So in general, the charts available for review have to reflect kind of the population of interest that you want in your study. As was mentioned earlier, I do some studies with out-of-hospital cardiac arrest. The vast majority of out-of-hospital cardiac arrests never make it into the emergency department or at least the inpatient setting. So I have to be sort of aware of that if I'm looking only at cardiac arrests that make it to the emergency department, I'm missing a subset of out-of-hospital cardiac arrests that were managed only by the pre-hospital providers with resuscitative efforts terminated on scene. You also need to make sure that your charts that you're going to be reviewing for your study have external validity. And this comes into play a little bit with prospective studies and randomized trials, but it's even more important for chart review, especially if the charts were taken from a practice setting with an atypical population or a unique practice style. The results that you find may not be generalizable to the places where your peers practice. The other thing is that you need to make sure that the electronic record from which you are taking your data contains documentation of the pertinent study items. There's a lot of things that maybe you document for every patient and you assume your colleagues do, and you may get into the chart reviews and find that your colleagues don't document the same way that you do. For example, like GCS score, you might think that every trauma patient gets a GCS and then get in there and realize that, or an NIH stroke scale and realize that not everybody does that for every stroke patient or every trauma patient. One of the things I've encountered in my own research is the Wells score for PE. So one big element of the Wells score is whether PE is the #1 diagnosis or equally likely diagnosis. So it's nearly impossible to calculate a Wells score retrospectively, because very rarely do we discretely state in our chart, like, my #1 diagnosis is PE. If a Wells score is calculated, that's great, but it's often not. So in that study, we ended up using the Geneva score instead of the Wells score, because the Geneva score is another risk stratification score that includes more objective, discrete variables that we could pull more easily from a retrospective chart review. And then finally, in your planning stage, you'll need to make sure that you do have an adequate sample size. For some things, this is very obvious, and it's easy to just increase the number of years that you're studying if you need more patients. But for things like rare exposures, toxic exposures and venimations, you may need even more data that you can get over a multi-year study at your own institution. So it might be worth reaching out to colleagues to see if they're interested in collaborating with you and contributing some charts to your chart review. Beyond that, I agree with everything Dr. Pruitt said about planning carefully and really thinking about how you're going to operationalize your clinical concept and where you're going to pull things from the EHR. Really thinking, like, if you want patients with a chief complaint of abdominal pain, what are you considering a chief complaint of abdominal pain? Are you including epigastric pain? Are you including pelvic pain? Are you including flank pain? All those little things that go into how you define abdominal pain. That's just one example, but I think planning is key, and it will make the rest of your study so much easier.
I'm going to ask a follow-up question just now that we didn't have discussed earlier, and hopefully it'll be pretty straightforward. Is both of you had talked about how to collect your data, and particularly I think that Dr. Muma, you had mentioned REDCap, but what sort of programs or how do you feel is most helpful to be able to collect that data from a technical standpoint?
So I am a REDCap fan. Particularly when working with junior data abstractors. So I've done projects where I've worked with undergraduate students. And for those who haven't used REDCap, it's a data management system, and you can create sort of the user interface that looks almost like a SurveyMonkey or a Google survey form, where they're inputting data into what looks like a form as opposed to inputting it directly into an Excel spreadsheet. And they will click a box, for example, for a yes, no question. They'll click a box for yes, or they'll click a box for no. And then on the back end, no will be coded as 0, yes will be coded as 1. So you'll have nice binary data for analysis. So I'm a big fan of REDCap. I certainly have used Excel, but Excel is not something I really recommend for data management, just because it is very easy to sort by one column only and not expand your sort, and you've just jumbled your entire data set. And that has definitely happened to too many people that I know. REDCap prevents you from doing that. Personally, I take my data from REDCap and then usually analyze it in Stata, with Excel kind of as an intermediary, but you can export directly from REDCap into Stata, SAS, SPSS, all those files, as well as files to label your data in the statistical programs.
So I said earlier I was a database nerd, and this answer will probably give me away as more of a database nerd, but I actually agree completely that I think REDCap is a great answer for most retrospective studies. I think unless you're doing very, very large data set management, one of the big problems that I encountered was we had to take all of this data from our enterprise data warehouse, and that included like notes that were like hundreds and thousands of characters long, which REDCap doesn't have as much. And there were kind of multiple notes per patient. So we had kind of a one-to-many data situation, which REDCap is less good at managing and is less efficient at managing. So because of that, I ended up being kind of almost forced to use like an SQL database. And then I kind of created then kind of baby access databases that my abstractors could have and could do the abstraction there. We run into some issues there because access is only available to people who use PCs. And there are kind of even some other limitations there. So I think REDCap is for 99% of people the best option. You can use Access as I think a good secondary option. I would probably use Access over Excel in most situations for data abstraction, simply because you can generally also make an Access form that makes data entry much quicker than it is through Excel.
Thanks. And for people who aren't aware, most universities or hospitals do have access to REDCap, and it's something that's free. And to Dr. Pruitt's point, it does allow for what's called branching logic, which I found has been really helpful in the past to be able to skip questions and speed things up. And then also it's HIPAA compliant at most universities, and it allows you to code that data. So that way, when you're exporting it, you can work with a de-identified data set for your IRB, which is some nice aspects to the software. And I definitely agree with both of them, that it's a great software for simple and even entry level, and a great way to get started with retrospective chart reviews if you haven't before. Our next question is, what are some pearls and pitfalls of these types of investigation in regards to reporting your results and then also getting published down the road? And I think Dr. Muma, you're first this time.
So if we haven't already mentioned it, one important pitfall is not planning carefully. I think especially because chart review studies can also be completed with an expedited IRB review and no grant funding, it's tempting to just kind of jump into them without carefully thinking through and planning all the things we mentioned: the study population, the data dictionary, your sample size, analysis plan. I think even for a chart review study, it's really, really important to meet with a statistician before you start to figure out how many charts you need to review, what your analysis plan is, and how you're going to collect your variables and your data so that they can be analyzed easily. And then once you've done the study, I think the other pitfall is not adequately acknowledging the limitations of your approach. Chart review studies can, they're certainly not at the top of the hierarchy in terms of the quality of evidence for changing medical practice, but they're not bad studies. You just have to acknowledge the limitations that a chart review approach has. And I often begin kind of the limitations paragraph of my manuscript with something along the lines of, the major limitations of this study are inherent to its retrospective design. Just be honest, put it out there, and acknowledge it, both in your limitations paragraph as well as in your conclusions. Make sure that your conclusions don't overstate your results.
I'll add a couple things. In the planning phase, this is pretty basic, but make sure you do a thorough literature review to make sure that someone hasn't already answered your question. There's nothing worse than doing a whole study, writing it up, and sending it in, and having a reviewer one send you something back that says, "What about this?" And that can really that can be a bummer. Try to keep your study variables and outcomes as discrete as possible. I've talked about that a little bit before, but minimizing bias and interpretation. Reviewers will pick apart. If you say, we'll pick apart your outcome and say, how is it not this? How is it not that? Where was could this be a source of bias? It's really hard to do that with mortality. It's, that's, again, I'm going to go back to that, but the really discrete outcomes are the ones you want to think about. Don't spend a ton of resources trying to answer a question retrospectively. That would be better answered via a prospective study. If you're testing an evaluation and intervention for a common condition, that's probably not a great thing for a retrospective study, and you might be able to get that published as preliminary data for a prospective study, but you're probably not going to hit a big time journal with that. So just use your resources carefully. And then, and Dr. Mum, we talked about this a little bit, but don't overstate your conclusions. Without kind of advanced causal inference mechanisms, the most a single retrospective study can do in isolation is show an association. And similarly, with a few minor exceptions, you don't really want to be writing in your conclusions, my small retrospective study on X should mean that we all change our practice to Y. Those reviewers are going to jump in on that and are going to be really hard on that. And it's going to make reviewers question kind of the entire validity of your science. So you want to kind of phrase it as most of the retrospective studies I published have ended with prospective validation. We think we can do this. And so you want to be really careful in your conclusions about how you're phrasing it.
And to do a follow-up question, because you both sort of alluded to it, and I think the first time I tried to get published, I got rejected, obviously, because that's what happens to most of us on our first try, and got really disheartened, didn't resubmit to another journal because I didn't know that that's really how it works. Can you talk a little bit about how you select your journals? Which emergency medicine journals or other journals do you think are more friendly to retrospective chart reviews in your experience?
So I think it's important to think about which journal you might submit this study to from the beginning. The two big ones in emergency medicine that we think about first are typically Annals of Emergency Medicine and Academic Emergency Medicine. But I would also encourage people to think outside the scope of emergency medicine. There are, depending on I've certainly published in several of the cardiovascular journals. Depending on your topic, you might be publishing in the neurology journals or pediatrics journals. So I think it's important to just really look broadly before you begin and get a possible target, but I don't think that you don't need to decide where you're going to submit your manuscript before you start your study.
I agree.
Okay. We do have a question in the chat, which we'll stop and talk about now, as opposed to holding it to the end, because I think we'll have time. One of the fellows from Mayo Clinic has asked, I would like to ask you a question. How can we make a REDCap form more user-friendly when we consider many factors together?
I can start with this one. I'm not sure what's meant by many factors together, so feel free to kind of put in the chat if you want to expand on that a little bit more. But making REDCap user friendly, I think the first thing is just, so in REDCap you have variable names, and then you have variable labels, and your variable label should be, I write it out as like a full text question, like, did this patient have chest pain on arrival to the ED ? Yes, no. I don't just say chest pain ? I am very specific about, the time and where I want them to look. And sometimes I will even say, look at the triage note, the chief complaint, and the ED physician note to obtain this information. So the more specific you can be, even with lab values, hopefully you can just have one of your IT analysts directly export them. But if for some reason you do need to, manually extract lab values, be clear to say, take the first creatinine value from the encounter, not the one on like day 2 of the hospital stay or the one before they were discharged. And then again, trying to provide very clear criteria. For example, in one of my studies, we had to report the results of stress tests, cardiac catheterizations, and echocardiograms, and what is an abnormal versus a normal cardiac catheterization. What percent narrowing in how many vessels constitutes a cardiac catheterization that's positive for acute coronary syndrome. And sometimes you need to bring in experts from outside your field to make sure that whatever definition you're creating aligns with the generally accepted definitions. And then once you've agreed on that definition, put it into the data dictionary so everybody knows that greater than 70% blockage or greater than 50% blockage is considered significant.
I would agree. I will add in something that Dr. Perry referenced as well, which is try to use branching logic as much as possible. If the patient is discharged from the ED and you can check that box, then make all of the admission questions go, like all of the questions about what happened during their hospital admission, go away. That'll save your abstractors some time. Similarly, try to abstract 10 yourself, like before you pass it off to the abstractors, so that you can tell kind of where the bottlenecks are, where the issues are going to come up. And then if there are, we want to make sure that our questions and kind of data points are pretty well set before. But if there are issues that your abstractors bring to you in terms of this doesn't work very well this way, you can go back and make changes to that. I just wouldn't make changes to kind of the discrete data elements.
Yeah, I will add one thing we've done is occasionally we've had to add categories, for example, like ECG data, going back and adding categories because I kind of monitored how often people were selecting that an other finding was present. And after the first 100 charts or so, if the other finding that was present was consistent across charts, then we would just add that as an option. And you just have to go back and fill in some data for the charts that you've already reviewed. But it's still better to do that after 50 or 100 charts than it is to get to the end of your study and realize you wish you'd done that for 1,000 charts.
And this is where maybe it's helpful to have meetings with your team frequently, go over questions, concerns, to help avoid some of those issues. The other thing I would add is that the intention of language, and to Dr. Muma's point, making sure that you're as discreet as possible, because what you might write in your REDCap, the abstractor or the person looking at it might think something's different. And then when you design your REDCap, which I've found as well, and Dr. Pruitt alluded to, is that sometimes, going through them, you'll realize that the data that you would want to collect in that direction or in that order may not show up in the chart in that direction. So when you're going through and making sure that your data, the person who's abstracting your data collects it in the same way that they're going to see it, will help to speed it up as opposed to click through multiple tabs in different directions going back and forth. Thank you for that question. If anyone has any others, feel free to put those. Some of them we will hold at the end. If someone was interested in a retrospective chart review, what resources would you recommend to learn more about, and what areas do you think might be some of the might be some interest topics of research? So Dr. Pruitt.
So as we've kind of discussed, it's really easy to do a, it's not easy, but it's easier to do a methodologically flawed chart review than it is to do a methodologically strong one. So making sure that you're planning beforehand and and making sure that you're addressing the key concerns beforehand. I'm going to throw into the chat two of probably the best articles about retrospective chart reviews in emergency medicine. One of them is an old one from 1996 by Gilbert and Lowenstein that was published in Annals and kind of goes over kind of these are the big things you want to think about. The next is from 2014 by Amy Kachi, David Schreiger, and Steve Green, talking about reducing bias in these studies. And they give you a really good idea of how to kind of structure your chart reviews. And a lot of kind of the advice, at least that I'm giving today, is based on the principles that are outlined in those articles. For reporting of your results, I would highly recommend using a checklist to make sure that all of your critical elements make it into the final paper. And many journals are now requiring you to put these in, but I think it's a great exercise no matter what. For most of these studies, we're going to use the STROBE guidelines, which are the strengthening the reporting of observational studies in epidemiology. I guess the B comes from OBS, those are really good. They're actually also, in addition to the checklist, there are explanatory papers that accompany those checklists that have really good examples. And so that can be a really helpful way if you're unfamiliar with the methods and if you're unfamiliar with the reporting guidelines. Those can be a really good way to learn how to report these key elements. And I will throw a link to the STROBE guidelines in the chat as well. I don't really have any specific areas, but I would think about kind of rare conditions or things where you're like, I'd like to get some funding for this to do a prospective study later. And so yeah, that's probably where I'd start.
I agree with everything that Dr. Pruitt just said. The two articles that he mentioned, particularly the second article, the Kaji, Schreiger, and Green article, is fantastic. And that is also the first resource that I give any mentee I'm working with who's doing a retrospective chart review study, just to help them understand why we're doing things the way they are. And then to help them understand, if they're drafting a manuscript, the elements that need to be sort of mentioned in the methods section of the manuscript. As a journal reviewer, I've seen many manuscript submissions that do not address these elements of chart review. And whether it's true or not, your reviewers will generally not give you the benefit of the doubt. They'll assume that if you didn't report these steps, you didn't complete them, or maybe even that you're hiding something, and they'll get suspicious, and then the review can kind of spiral out of control. And the other thing is, it's okay if you can't hit every criterion on that list, particularly when you're more junior and you're doing your own chart review. When I review charts for my own studies, I can't blind myself to the hypothesis. Like, I created the study, I designed the study, I wrote the hypothesis, I'm not blinded to it, but I still need to be involved in the chart review process and in training people. So it's almost impossible to get all bias out of a chart review study. The goal is to minimize the bias as much as you can, and where there is the potential for bias, to call it out and acknowledge it and discuss the potential direction of the bias and how it may affect your results. It's just really important to be transparent in your reporting. And then the only other key consideration I would say is something that we sort of touched on before, and that's really thinking carefully about which data elements really need to be manually abstracted via chart review and which may be able to be curated and then directly extracted by an analyst. So I think we talked already about vital signs, lab results, things that exist as a discrete data point that just can be pulled right out of the EMR. But then there are also elements that maybe don't exist discretely, but can be curated and extracted. And this is where, I lead a data curation team here at UC Davis, and we've curated the concept of a past medical history of hypertension using a combination of entries from past history, problem list, and diagnoses in the EHR. So if you think about it, in most versions of EMR, there's no question that says, does the patient have a history of hypertension? Yes, no, that you can pull it out as a discrete field. But you can sort of recreate the manual chart review process by looking everywhere in the chart that a manual reviewer might. We've also curated the Elix-Hauser comorbidity index score, and that score can be automatically calculated for each patient in a data set as the data are extracted from the EHR, and that's code that's just reusable across research studies. It's not a resource that exists everywhere, and I think it really depends on having a strong analyst, but it is certainly worth talking to mentors, talking to colleagues, talking to IT, and seeing what's available at your institution.
Thank you both for that. And for anyone in the audience, I would recommend, if you haven't been to, Annals of Emergency Medicine has an outstanding website which helps to direct people who are looking to conduct research about important articles or checklists, and the preferred reporting and methodology for research, which is very, very helpful. And I think that actually both of the articles that Dr. Pruitt included in the chat are listed on that website. And since we're talking about it, what's that, Peter?
I was just going to say, I think that Dr. Muba brings up a key thing that you may want to think about, which is kind of small data chart reviews, which I would argue is kind of chart reviews that go into the thousands, and then what we're getting into and what we're seeing more and more, which is very big data chart reviews. So chart reviews where we're looking at tens of thousands of patients, chart reviews where we're gathering data from entire health systems to be able to do that. And on those, we may want to start thinking about, you may want to take abstraction to another level, which is like using natural language processing, using things like that to review notes, to review CT scan reports, and actually training algorithms to be able to do that on this scale of kind of tens of thousands of charts. One of the things as part of what we've done in the past is we created a natural language processing algorithm that takes out subdural hematoma characteristics from like the CT scan reports, so that we don't have to have abstractors do that. We can just kind of run that NLP algorithm, and then it just abstracts it. It's kind of the most rudimentary level of NLP. And so I think if you're going to start thinking about kind of, this is a question I want to answer with very big data, then I think you may want to, and this is obviously beyond the scope of like me and one other person trying to do my chart review without any funding. This is more of I'm going to apply for a grant to do this. I'm going to start kind of finding external collaborators in schools of engineering and things like that to be part of this with me. But if you start thinking about really big data work, you may want to start thinking about not the question of how do I best create this, not of how do I best create this form, but like how do I best create the algorithm that's going to extract the data, or how do I do what Dr. Moon was talking about in terms of kind of that data curation work. And if you set that up beforehand to where you can easily get that data out of your EHR, then you can really start asking, questions on much bigger data sets.
Thank you both for that. I think we'll have time to answer this before we go to some of our additional questions. And if anyone does have questions, we've gone through our set questions. We do have some backup questions and things to talk about, but if anyone does want to ask anyone, I would encourage you to include those in the chat. One person does ask, could you please recommend a good source of information for writing a hypothesis?
So I think there are a lot of resources available online. I like the approach Dr. Pruitt mentioned earlier for framing sort of your research question and then your hypothesis. The PICO format, so patient, intervention, comparison, outcome. And all of those elements should be in your question, but then all of those elements should also be in your hypothesis. And your hypothesis for a chart review, which we assume is a quantitative study, really needs to be a testable hypothesis. So not just like, we think we'll find something, but it really needs to be a testable hypothesis. Put a number in so that you can say, yes, this is true, or no, this is not true.
I agree.
Thank you. Next, we'll go on, and we've also sort of alluded to it as well before, but how do you feel retrospective chart reviews should be valued in the hierarchy of research literature? For example, RCTs, prospective studies. Do you think they should be used to change clinical practice ever? Dr. Pruitt, do you want to start this time?
Sure. So I'm not like kind of one of those like evidence-based medicine pyramid absolutists where I'm like, no, we only change practice based on a meta-analysis that is composed of high-quality randomized controlled trials. I'm not, jump the study of people, the old study of people, of EBM experts jumping out of airplanes and do they need a parachute? We're not arguing about that. But I do think that you have to be pretty selective in where you're going to use retrospective chart reviews when they're the only feasible study type for ethical reasons. So we're never going to randomize people to smoking or not smoking. We're always going to use observational data to determine whether or not to know that smoking is bad for you. We want to see a lot of retrospective studies that show us the same conclusion. And we generally want pretty rigorous methodologic scrutiny. And you don't want a bunch of studies from one person or one group That's where you get kind of those dangerous studies where you see kind of like the studies that linked, vaccines to autism, which are really looking at spurious correlations, but it's really easy to find those things when you're looking retrospectively, and especially when you're looking retrospectively and you have an agenda. So that's where if you can kind of find some external sources and some external experts to validate it, that's going to make everyone, and at least me, a lot more comfortable with saying that we're going to want to change practice on it. But really, like, practice change should be if it's really not feasible to do a randomized controlled trial. But in COVID, we weren't going to be able to do randomized controlled trials. In kind of rapidly emerging things, we weren't going to be able to do randomized controlled trials that quickly. We had to base some of that on observational data in the beginning until kind of trials were able to take hold.
Yeah, I absolutely agree. In general, retrospective chart reviews alone are unlikely to change clinical practice in most scenarios, for all the reasons Dr. Pruitt mentioned. But there certainly are situations in which they have appropriately changed clinical practice, and many, many more situations where they have paved the way for the key clinical trials that have changed practice. And I think that's a really valuable role that retrospective chart reviews have, is sort of setting up something that needs to be further studied with a clinical trial or a prospective observational study. And a lot of times they're very helpful when you're getting ready to submit a grant application and somebody says, well, how do you know this study needs to be done? Prove it. And a retrospective chart review can also prove the need for the next study.
Excellent. And one of the things that I think a lot of reviewers and people, when they're reviewing a retrospective chart review, think about is like the quality of the data. How do you assess that, ensure that when you're preparing and doing your study? Who wants to go first? Dr. Pruitt?
Okay. So, I think a few key questions here. How much of the data was missing? Are there any key sources of bias in the missing data? I think that you may, as you're kind of, and this, I think I'm answering this kind of more with a journal reviewer hat on than I am as a person who's kind of as a preparer of retrospective chart reviews. But preparing a patient flow diagram, making sure that your study contains a patient flow diagram at the end. This is how many patients I excluded for this reason. This is how many patients I excluded for this reason. This is the total number of patients that made it to our comparison. Was the data collected from all the relevant patients? Were there any patients that were systematically excluded that could affect the study results? You want to go back and look at your abstractors and see if there are any systemic bias in the results per abstractor. So, for example, if like 10% of your patients are on anticoagulants in one of your abstractor sample and 1% in the other, you got to figure out if one abstractor is looking at kind of anticoagulants in a different way. Are they including aspirin in there? And then interrelator reliability, so kind of collecting TAPA statistics, is a good way to determine that information. And then finally, look at table 1. And this is something I tell people to do in any retrospective study they're reviewing too, or reading. Look at table 1. Does table 1 match both kind of your face kind of assumptions about your patient population? Like if table 1 shows that you see, 50% of patients over 65 and you work in the PZD, that's probably a problem. And you really need to decide kind of, does that match your patient population? And then similarly use that when you're assessing a retrospective study and deciding if you're going to bring it into your clinical practice. Are the patient characteristics in table 1 like what your patient characteristics look like?
I agree. One of the main things that I see as a journal reviewer is that there's no what I call figure 1 for a retrospective chart review, which is that patient flow diagram. And I generally whenever possible, like to see it start with like the total number of patients seen in the emergency department during the study period and work down from there, which is sometimes a little difficult because typically you'll get a data set that just has the medical record numbers you are including. So a lot of times people will start with the number of patients who came in with abdominal pain and then exclude from there. But if at all possible, it's really nice to see the total number of ED patients seen during the period and why they were all excluded. I agree about missing data, inter-rater reliability. There are other ways other than a kappa coefficient to calculate inter-rater reliability, but again, that's something to talk with your statistician about. Kappa is generally pretty widely accepted. And then I think the other thing to consider with missing data is to look and determine whether the data are missing at random as opposed to missing systematically. And if you do determine that they're missing at random, you may be able to impute the missing data. The procedures for that sort of warrant an hour-long lecture in and of themselves, but just be aware that there is a method out there that you may want to talk with a statistician about if your data are missing at random, because you can use other variables that do exist in the database to predict what those missing variables would be. And the benefit of that is that if you're doing a multivariable model, any patient who's missing any variable in the model is automatically dropped from the multivariable model. Whereas if you can impute the variables that are missing, then you can keep your entire patient population in your multivariable model. There are sometimes, though, I can give an example where we were doing a study of pediatric abdominal pain, and we were looking at disparities in analgesia administration, and we were adjusting one of the variables in our multivariable model was the pain score. And pain scores are supposed to be documented on all of our pediatric patients, but we found in our data set that there was one patient under the age of 5 who had a pain score documented. So they are obviously not missing at random, they are missing based on age. So we ended up having to drop all of the patients less than 5 years of age from our data set in our analysis because we weren't able to impute that degree of missing data.
Thanks for that. And to follow that up, if you're using a computer analyst or someone who's abstracting the data for you and you're not doing a manual chart review, how do you ensure that that data is accurate? Do you go through and double check a couple of the charts to make sure, or do you do a kappa versus your computer analyst? What do you think is the best way to deal with new sort of updates? Because 20 years ago, most chart reviews were all completed manually. Dr. Pruitt, maybe I'll start with you because
I like to go back and look through and just make sure that, like, do a couple for a truth check. Discrete lab values, it's hard for them to mess that up. It's not impossible. But for kind of anything that is not validated or that's been abstracted by someone else or that is kind of from a large data set otherwise, I think going back and trying to find the truth and your gold standard somewhere and looking at a couple of those and making sure that you agree with it is really important. And whatever sample you decide, and report how many you double checked.
I agree. Our data curation team uses an iterative process where we require that the data requester validate a certain percentage of charts for us to feel comfortable releasing the data. And then that percentage of charts that's reviewed then can go into the methods. And there are certain variables that are more sticky than others. Vital signs, lab results, things like that, chief complaint are usually pretty straightforward, but there are others that certainly require a lot more iterative data curation and therefore a lot more charts to be reviewed.
Thank you both for that. I do want to ask the audience if there's any last questions. We are nearly at the top of the hour, and we have 2 outstanding experts in the field if anyone wants to ask any more questions.
There was a good question in the chat about what does the process look like of getting data after you get the IRB approval? And I would end up probably having to leave it at that varies a lot based on your institution. A lot of institutions have started building data warehouses, which is where you request the data otherwise. Sometimes it's something you can build from your electronic health record. A lot of places also have now developed based on, I think, something out of Partners Harvard, but there's this I2B2 model, which is a way to get kind of a count of the number of patients meeting a certain ICD-9 code that you have. And then generally what you'll end up doing is saying, I want to pull the number of patients who have the following ICD-9 codes, and then talk to whoever your data stewards are about how to get that data.
Dr. Muma doesn't have anything to add. I do want to encourage people to check out the SAEM website where all of these get listed and will be uploaded to review. So if one of your colleagues or whatever was not here to listen, they can go back, or if there's something you want to re-listen to, definitely look for this. And there's others that'll be coming out shortly, which are outstanding resources if you're looking to get started about research. So thank you again to Dr. Muma and Dr. Pruitt for joining us today and your insights, and want to thank all the people in the audience who asked questions and came in to join us today. Thank you very much.
Thank you.
Thank you so much for having us. And anyone's welcome to reach out to me afterwards as well. My email's available through the SAEM community site.
In here. Thank you.